Welcome back to the deep dive. We've got an incredibly detailed set of sources today, all focused on the advanced anatomy of the head and neck.
Sure.
Our aim isn't just to skim the surface, but to really transform this dense material into, well, true mastery.
Exactly. This is for listeners aiming for that elite professional grasp. We're not doing highlights, we're going deep. We'll be tracing complex nerve pathways, understanding the sheer genius of how the orbit works and navigating those neck spaces, the fascial layers. And that can mean life or death.
Yeah, understanding how infections spread there, for instance.
Precisely. We're synthesizing everything needed to grasp the real clinical weight of these structures.
It really is a roadmap then. And like any journey, we need a starting point. For this complex region, that has to be the foundational network, right? The roots of motor, sensory function.
Absolutely. We start right at the brainstem with the 12 pairs of cranial nerves.
Okay, 12 pairs.
Yeah.
Coming straight off the brain or brainstem, not the spinal cord.
Correct. And each one is distinct functionally, geographically. They pass through very specific holes in the skull, the foramina and fissures, to get where they need to go.
So the first way to get a handle on them, that first layer of organization, is function, right? Sensory, motor, or both.
That's the logical starting point. Makes it much easier to categorize. So let's see. The pure sensory ones first. The input specialists.
Right.
We've got cranial nerve 8, olfactory, that's just smell. Then CN2, the optic nerve, purely for vision. And CN8, vestibulocochlear, which handles hearing and balance. 3 dedicated sensory inputs.
Got it. Olfactory, optic, vestibulocochlear, sensory only.
Then the motor outputs, the action nerves, there are 5 of these.
Okay.
3 are all about moving the eyeball. CN the third, oculomotor, CN4V, trochlear, and CN the abducens. We'll definitely be digging into those later.
Eye movers.
And add to that CN8, the accessory nerve, and CN12, the hypoglossal nerve for tongue movement mainly. So those 5 are purely motor commands.
Oculomotor, trochlear, abducens, accessory, hypoglossal. Pure motor. Okay.
Which leaves the last 4. The mixed bunch. These guys do both sensory and motor. They're arguably the most complex.
Who's in this group?
CNV, the trigeminal huge nerve, does sensation for the face, motor for chewing muscles. CNV7, the facial nerve, think facial expressions plus taste. Then CNIX, glossopharyngeal, and the big one, CNX, the vagus nerve.
Ah, the vagus. That one always stands out. Kind of breaks the rules, doesn't it? Doesn't just stay in the head and neck.
It absolutely does. Vagus means wanderer, and it lives up to the name. It's the only cranial nerve that sends significant branches outside the head and neck.
Where does it go?
It extends way down into the thorax, the chest, and even into the abdomen. It's providing crucial autonomic control parasympathetic to major organs, heart, lungs, digestion, you name it. Understanding the vagus is key to understanding how the body regulates itself below the neck. #3, the orbit and its protective structures.
Okay, so with that nerve foundation laid, let's apply it. Let's move to the orbit. The eye's bony fortress. It seems simple, but it's actually a really intricate pyramidal shape.
Yeah, that pyramid shape is key. The base, the opening, faces forward. The apex points backward towards the inside of the skull, the middle cranial fossa. And it's packed full. You've got the eyeball, obviously, but also all the muscles moving it, nerves, blood vessels, and a lot of fat cushioning fat.
Let's talk about the walls, the
Yeah.
bones. Because what forms the margins tells you a lot about potential problems like fractures.
Definitely. The top edge, the brow ridge, that's the frontal bone, goes sideways, laterally. And you have the frontal bone again, plus the strong zygomatic bone, your cheekbone.
Okay.
Inferiorly, the bottom edge, it's the zygomatic and the maxilla, the upper jawbone. And then medially towards the nose, you've got the maxilla, the frontal bone, and crucially, the ethmoid bone.
Right, and the thinness of some of those walls is really important clinically, like the roof.
Exactly. The roof is mostly the orbital plate of the frontal bone, plus a bit of the sphenoid bone. It's thin. And what's right above it, the anterior cranial fossa, holding the frontal lobe of the brain.
So trauma pushing upwards.
Can potentially go right into the brain cavity, or infections, tumors. It's a direct link.
And the floor, what's beneath that?
The floor is mainly the maxilla's orbital plate, also thin. And directly underneath it, the huge maxillary sinus airspace.
Ah, the classic blowout fracture site.
Precisely. Sudden pressure increase in the orbit, like from a punch, and that thin floor can just pop downwards into the sinus.
And the medial wall towards the nose, also vulnerable.
Very much so. It's largely the ethmoid bone's orbital plate. It's incredibly thin, sometimes called the lamina papyracea, the paper thin plate. And right next door are the ethmoid sinuses.
So sinus infections.
Have a very easy, direct route to spread right into the orbit through that fragile wall. big clinical concern.
Okay, moving out from the bone, let's look at the eyelids. The mobile protective covers. The upper lid's bigger, moves more.
Yep, much more mobile. And opening the eye, lifting that upper lid, involves two muscles. The main one is a skeletal muscle, levator palpebrae superioris. But there's also a small, smooth muscle, the superior tarsal muscle, which gets sympathetic nerve input.
And closing. Just letting it drop.
No, closing is an active contraction. It's the orbicularis oculi muscle, that big circular muscle around the eye squeezing shut. That one's run by the fascial nerve, CN and ZF.
Got it. Now, eyelids aren't just skin and muscle. They've got glands, right? For protection, lubrication.
Three main types, yeah. You've got the sebaceous glands of Zeiss, right at the base of the eyelashes. Then the ciliary glands of Moll, which are basically modified sweat glands.
Okay.
And then the really important ones for the tear film, the tarsal glands, or meibomian glands. They're embedded deep in the lid structure. They're modified sebaceous glands, and they produce an oily secretion.
And why is that oily stuff so crucial?
Two big reasons. First, that oil creates surface tension at the lid margin, stopping your tears from just constantly spilling over and running down your cheek. Keeps the tear film stable.
Makes sense.
Second, when you close your eyes, that oily layer helps make the seal truly airtight. Protects the cornea from drying out overnight, keeps dust out. Really vital.
Okay. And lining the inside of the lids and the front of the eye, the conjunctiva?
Right. It's a thin mucous membrane. Lines the eyelids, that's the palpebral conjunctiva, and then folds back onto the eyeball itself, the bulbar conjunctiva. Those folds, top and bottom, are the fornices.
And that creates a space.
Yeah, the conjunctival sac, it's a potential space, open only at the gap between the lids, the palpebral fissure.
And somewhere in there, there's that little groove that always seems to catch tiny bits of grit.
You mean the subtarsal sulcus, yes. It's a shallow groove on the inner surface of the eyelid near the margin. Perfect spot for trapping small foreign bodies. When a doctor flips your eyelid inside out, that's often exactly what they're looking for.
Right, okay. And finally, what gives the eyelids their structure, their shape?
It's a fibrous framework. The main sheet is the orbital septum. This gets thickened at the lid margins into these dense plates, the superior and inferior tarsal plates.
Like little stiffeners.
Exactly. They give the lids their form. And these plates are anchored firmly to the bone at the corners of the orbit by the medial and lateral palpebral ligaments. Holds everything in place, provides tension for smooth movement.
Okay, next layer of protection. Moisture. The tears. That's the lacrimal apparatus. Produces tears, drains tears.
Correct. The lacrimal gland itself, the tear factory, is tucked up high and laterally in the orbit. It actually has two parts, an orbital part and a palpebral part, kind of wrapped around the edge of the levator muscles tendon. Importantly, it sits behind the orbital septum, so it's well protected within the orbit proper.
So tears are made up there, then they flow across the eye.
Yeah.
Where do they go next? Let's trace that whole drainage path down to the nose.
Okay, so tears wash across the eye surface, collecting medially near the nose in a little pool called the lacus lacrimalis. From there, they get sucked into two tiny openings, the puncta lacrimalis. You can just see them on the little bumps, the papillae on the lid margin.
Right, those tiny dots.
Those puncta lead into narrow tubes, the canaliculi lacrimalis. These then merge and empty into the lacrimal sac. Think of the sac as just the expanded, blind upper end of the main drain pipe.
Which is
the nasolacrimal duct. This duct runs down through a bony canal in the skull and finally opens into the nasal cavity, specifically into the inferior nasal meatus, beneath the inferior turbinate bone.
Okay, hold on. A direct pipe from the eye drainage into the nose.
Yeah.
What stops air shooting back up when you, blow your nose really hard? Seems like it would force air right back into your eye sac.
Good question. There's a neat little safety valve, a small flap of mucous membrane called the lacrimal fold, guards that opening down in the inferior meatus. Its whole job is to act like a one-way valve, preventing air from being forced backwards up the duct. Clever design.
Very clever. Okay. Now for the really complex bit. The nerves that make the lacrimal gland actually produce tears. The autonomic innervation. This pathway is notorious, right? Nerves hitchhiking on other nerves.
It is definitely one of the classic complex pathways, requires real focus. Let's break down the parasympathetic side first. That's the on switch for tear secretion.
Okay, step by step, where does it start?
The journey begins in the brainstem, in the lacrimal nucleus, which is associated with the fascial nerve, CN. The preganglionic fibers leave with CN7, then branch off as the great petrosal nerve.
Great petrosal. Okay.
This nerve travels forward across the floor of the middle cranial fossa. Then it gets joined by sympathetic fibers, the deep petrosal nerve, to form a combined nerve called the nerve of the pterygoid canal.
Okay, composite nerve. Where does that go?
It dives deep into the skull, entering the pterygopalatine fossa, and there the parasympathetic fibers finally find their target synapse point, the pterygopalatine ganglion.
Synapse happens. Now, postganglionic fibers head to the gland.
Not directly. This is the hitchhiking part. The postganglionic fibers jump onto the big maxillary nerve, V2. Almost immediately, they switch over to a branch, the zygomatic nerve. Then they switch again onto another branch, the zygomatico-temporal nerve. And finally, right near the orbit, they jump one last time onto the lacrimal nerve, which is actually a branch of V1, the ophthalmic nerve, to reach the lacrimal gland.
Wow, okay, let me recap that. CN is a 7-nucleus great petrosal nerve of pterygoid canal synapse and pterygopalatine ganglion. Hitchhike on V2, zygomatic N, zygomatico-temporal N, final jump to lacrimal N gland. That is convoluted.
It truly is a 3-nerve, 1-ganglion relay race. And the crazy thing is, the sympathetic fibers, which mostly control blood vessels in the gland, they follow almost the exact same route.
Seriously, where do they come from?
They start as postganglionic fibers wrapping around the internal carotid artery, forming the internal carotid plexus. A branch comes off as the deep petrosal nerve. This joins the great petrosal to form the nerve of the pterygoid canal.
And then just follows the same sensory highway.
Exactly. Through the pterygopalatine fossa onto V2, zygomatico-temporal lacrimal nerve. The key difference is the sympathetic fibers do not synapse in the pterygopalatine ganglia. They just pass straight through. They're using the pathway purely for transit to the orbit. #V orbital openings and neurovascular transit.
Understanding the orbit also means understanding how things get in and out. The communication lines. These holes connect the orbit to the brain case, the face, deep structures.
Absolutely critical connections. Right at the very back, the apex of that pyramid, you have the optic canal. It's a tight channel, very protected, but it carries two absolutely vital things. The optic nerve, CN2 itself, carrying all visual info, and the ophthalmic artery, the main blood supply, which is the first major branch off the internal carotid artery.
Okay. Optic canal, CN2, and ophthalmic artery, with a big opening next to it. Looks kind of irregular.
That's the superior orbital fissure. It's the main gateway for almost all the nerves controlling eye movement.
So the motor nerves.
All three of them, oculomotor, CN3, trochlear, CN4AV, and abducens, CN3. Plus the main sensory nerve for the orbit and forehead, the ophthalmic division of the trigeminal, V1, and crucially, the superior ophthalmic vein exits here too.
Why is the vein so important there?
Because it drains directly backwards into the cavernous sinus, a big venous structure inside the skull. That makes this fissure a major route for infections from the face or orbit to spread into the cranium. Very dangerous potential pathway.
Yikes. Okay, third opening, down lower.
That's the inferior orbital fissure. It connects the orbit down towards the cheek area and the deep pterygopalatine fossa. It transmits branches of the maxillary nerve, V2, specifically the infraorbital and zygomatic nerves, also the inferior ophthalmic vein, which talks to deep facial veins, and some sympathetic nerves heading for eye structures.
Right, so 3 main portals: optic canal, superior orbital fissure, inferior orbital fissure. Now, we mentioned bones and nerves. What about the fascia, the connective tissue lining things?
Well, the bone is lined by periosteum, called the orbital fascia, but the eyeball itself needs more specialized wrapping. It's not just loose in the orbital fat.
No. What surrounds it?
It's encased in a smooth, thin fibrous sleeve called the fascial sheath, or bulbar fascia, sometimes called Tennant's capsule. This sheath effectively separates the eyeball from the fat around it.
Like a socket.
Exactly like a socket. It creates this low friction space that allows the eye to rotate smoothly in all directions within the fat padding.
Does that sheath help hold the eye up too? Seems like gravity would pull it down.
It does contribute. The lower part of this bulbar fascia is thickened and forms what's called the suspensory ligament of the eye. It's like a hammock slung between the medial and lateral walls of the orbit, supporting the eyeball from below, preventing it from sagging. #Z, the extraocular motor system in clinical testing.
Okay, let's get to the engines of movement. The 6 extrinsic muscles moving the eyeball. 4 rectus muscles, 2 obliques. Mastering their actions is like a benchmark, isn't it?
It really is. And it starts with that classic innervation mnemonic, SO4, LR63. You have to know this cold.
Break it down.
SO4. Superior oblique muscle is innervated by CNIV, the trochlear nerve, LR6. Lateral rectus muscle is innervated by CNVI, the abducens nerve, and the 3 means all the others, the superior rectus, medial rectus, and inferior oblique, are innervated by CN the 3rd, the oculomotor nerve.
SO4, LR6, all others 3.
Got it. Where do these muscles actually attach at the back of the orbit?
Most of them, the 4 rectus muscles and the superior oblique, arise from a common fibrous ring right at the apex, the common tendinous ring, which surrounds the optic canal.
But not all 6.
One exception, the inferior oblique. It's unique. It arises from the anterior floor of the orbit, near the lacrimal sac area. That different origin point is key to its specific rotational action.
Right. Now, describing eye movements just as up or in isn't precise enough for this level, is it? We need the axes of rotation.
Absolutely. Think of the center of the eyeball as the pivot point. Rotation around the horizontal side-to-side axis, the transverse axis, gives you elevation, looking up, and depression, looking down.
Okay.
Rotation around the up and down axis, the vertical axis, gives you abduction, pupil moves out laterally, and adduction, pupil moves in medially.
And the third the front to back axis, the sagittal axis, rotation here is, well, rotation, medial rotation. Top of the eye tilts inwards, intorsion, or lateral rotation. Top of the eye tilts outwards, extorsion. This rotational component is crucial for stabilizing vision during head tilts and coordinating with vertical movements.
Here's where it gets tricky, though. The superior and inferior rectus muscles. They don't just move the eye straight up and down, do they? They also rotate it medially. Why the complication?
It's pure biomechanics based on where they attach. The eyeball's axis points slightly outward, but the superior and inferior recti pull from a point slightly medial to the eye's vertical rotation axis.
Oh, okay.
So when the superior rectus contracts, yes, it pulls the pupil up elevation, but because of that angle of pull, it also pulls the top of the eye inwards, medial rotation or intorsion. The inferior rectus does the opposite, pulls down depression, and also causes intorsion.
So you need the oblique muscles to cancel out that rotation for pure up or down gaze.
Exactly. That's why coordinated action is essential. And it's also why clinical testing has to be so specific. It can't just say, look up and know which muscle is weak. You have to isolate them.
Right. So how do you isolate, say, the superior rectus? What's the maneuver?
The principle is to get the eye into a position where the muscle's line of pull matches the eye's axis for that movement. For the superior and inferior rectus, you test them when the eye is turned fully out, when it's abducted.
Why abducted?
Because when the eye looks outwards, the line of pull of the superior rectus aligns perfectly with the vertical axis. Its rotational component is nullified. So in abduction, the superior rectus becomes a pure elevator, and the inferior rectus becomes a pure depressor. If someone can't look up when their eye is turned out, you suspect a problem with the superior rectus, likely a CN third issue.
Okay, makes sense.
Yeah.
So logically, for the obliques, you test them the opposite way.
Yeah.
When the eye is turned in.
Precisely. The superior and inferior obliques are tested when the eye is fully adducted, looking towards the nose. The superior oblique's main jobs are intorsion and depression. When the eye is adducted, its depressing action becomes primary. So, to test the superior oblique, CN3, you have the patient look in and down.
And the inferior oblique.
Its main jobs are extorsion and elevation. So when the eye is adducted, its elevating action is isolated. You test the inferior oblique, part of CN3, by having the patient look in and up. This H-pattern testing allows a clinician to pinpoint exactly which nerve, 3, 4, or 6, might be compromised. Hashtag tag SIF7, the eyeball structure and refractive media.
All right, let's dive inside the eyeball itself. Structurally, it's often described as having 3 main layers or coats. Outer one first.
The outer layer is the tough, protective fibrous coat. Posteriorly, it's the white, opaque sclera. Think of it as the eyeball shell. The optic nerve punches through it at the back at a spot called the lamina cribrosa.
And anteriorly, it becomes transparent.
Exactly. The front sixth or so transitions into the perfectly clear cornea.
The cornea. That's the main focusing element, right? More than the lens, even.
Absolutely. It's the most important refractive medium, responsible for maybe 2/3 of the eye's total focusing power. That big change in refractive index from air to cornea does most of the bending of light.
And it has no blood vessels. How does it stay healthy?
It's a vascular, correct. It gets its nutrients purely by diffusion from the tear film on the outside and from the aqueous humor fluid on the inside. And it's incredibly sensitive, packed with nerve endings from V1, the ophthalmic nerve. That's why even a tiny speck feels like a boulder.
Okay, moving inward. Layer 2.
The middle layer is the vascular pigmented coat, also called the uvea. It has three parts. Posteriorly, the choroid, which is rich in blood vessels supplying the outer retina.
Middle part.
Anteriorly, the choroid thickens into the ciliary body. This is a muscular ring containing the ciliary muscle, which controls focusing. It also has processes that produce the aqueous humor.
And the frontmost part of this middle layer.
That's the iris, the colored part of your eye. It acts like the diaphragm of a camera, controlling the size of the pupil.
And the muscles in the iris control that pupil size. How does that work?
Two tiny opposing smooth muscles. There's the sphincter pupillae, which is a ring of circular muscle fibers. It's controlled by parasympathetic nerves coming from CM3. When it contracts, the pupil gets smaller, constricts. Happens in bright light or when focusing up close.
And the other one.
The dilator pupillae. These are radial fibers, like spokes on a wheel. They're controlled by sympathetic nerves. When they contract, they pull the pupil open wider, dilate it. Happens in dim light or during a fight or flight response.
Okay. Innermost layer, the business end.
A nervous coat, the retina. This is the light-sensitive tissue where photoreceptor cells, rods and cones, turn light into electrical signals. It lines the back of the eye, ending anteriorly at a scalloped edge called the ora serrata.
And there are specialized spots on the retina.
Two key ones. The macula lutea, a small yellowish area responsible for sharp, detailed central vision. Right in its center is the fovea centralis, the point of maximum visual acuity, packed with cones. Medial to the macula is the optic disc.
The blind spot.
Exactly. That's where the optic nerve fibers exit the eye and where the main retinal artery enters. There are no photoreceptors there, hence a physiological blind spot in our visual field.
Let's talk fluids. The aqueous humor. Where is it? What does it do?
It's a clear, watery fluid that fills the space in front of the lens, both the posterior chamber between iris and lens and the anterior chamber between iris and cornea. It's constantly produced by the ciliary processes.
What does John?
Maintains the shape of the front of the eye, provides that crucial intraocular pressure, and importantly, it delivers nutrients to the avascular cornea and lens.
And it has to drain out somewhere.
Critically important, yes. It flows from the posterior chamber through the pupil into the anterior chamber. Then, at the angle where the iris meets the cornea, it drains out through a network called the trabecular meshwork into the canal of Schlemm, which is like a circular drainage channel.
And if that drain gets blocked, that's glaucoma.
Precisely. If aqueous humor can't drain out properly, the pressure inside the eye builds up. That increased intraocular pressure, glaucoma compresses and damages the optic nerve fibers and the retina. It's a leading cause of irreversible blindness if not caught and treated.
Okay. Finally, the lens behind the iris. Elastic, clear.
Yeah.
Its job is fine-tuning focus, especially for near objects.
Exactly. It's a transparent biconvex structure. Normally, it's held under slight tension by fibers called the suspensory ligament, which attach it to the ciliary body. This tension keeps it somewhat flattened for distance vision.
So how does accommodation work? Focusing up close?
It's a neat mechanical trick. To focus on something near, the ciliary muscle inside the ciliary body contracts. Think of it like a sphincter muscle tightening.
Okay, what does that do?
That contraction pulls the entire ciliary body slightly forward and inward, closer to the lens. This relaxes the tension on the suspensory ligaments. And because the lens is naturally elastic, when that tension is released, it recoils, becoming more rounded, more convex. This increased curvature increases its refractive power, bending light more strongly to focus the nearby object onto the retina.
Clever. And presbyopia, the reason older people need reading glasses, is when the lens loses that elasticity.
Exactly. With age, the lens gets denser, less flexible. It can't round up as easily when the ciliary muscle contracts, so the ability to accommodate for near vision decreases. Needs help from reading glasses. Accommodation also involves pupillary constriction and eye convergence, all coordinated. #8, vasculature and essential reflex pathways.
Let's quickly cover blood supply. The ophthalmic artery comes off the internal carotid, enters the orbit. Any particularly critical branches we need to flag, one that stands out?
Oh, absolutely. The single most critical branch, clinically speaking, is the central artery of the retina. It branches off the ophthalmic artery and runs within the optic nerve to pierce the eyeball near the optic disc.
What makes it so critical?
It's an end artery, almost completely.
Meaning no backup supply, no collateral circulation.
Very, very little, if any, for the inner retinal layers it supplies. If the central retinal artery gets blocked, maybe by a tiny embolus from the heart or carotid artery, the part of the retina it feeds loses its blood supply almost instantly. This causes sudden, profound, and usually permanent vision loss in that eye. A true ophthalmic emergency.
Wow. Okay, and venous drainage. Blood leaving the orbit. Where does it go?
The main drainage is via the superior and inferior ophthalmic veins. They collect blood from the eyeball and orbital structures and drain backward, primarily through the superior orbital fissure.
And their destination.
They empty directly into the cavernous sinus, that critical venous channel within the skull on either side of the pituitary gland. Again, this direct connection is the highway for infections spreading from the face orbit into the cranium.
Right. Now, reflexes, the eye reflexes are classic neuroanatomy.
Mm-hmm.
Let's trace the direct light reflex shine a light in one eye. That pupil constricts. What's the pathway?
Okay. Light hits retina. Signal goes up optic nerve, CN2, through the optic chiasm, where some fibers cross, continues down the optic tract. But before it gets to the main vision processing center in the thalamus, some fibers peel off.
Where do they go?
They head to the protectal nuclei located in the midbrain. This is the crucial reflex center.
And from the protectal nuclei.
Here's the key bit for the consensual reflex. Neurons from each protectal nucleus project bilaterally to both sides, connecting to the parasympathetic nucleus of the oculomotor nerve, CN3. That's the Edinger-Westphal nucleus.
Ah, bilateral connection.
Exactly. So the motor command goes out via CN3, travels to the orbit, synapses in the ciliary ganglion, a tiny ganglion near the optic nerve, and then postganglionic fibers hop onto the short ciliary nerves to reach the sphincter pupillae muscle in the iris, causing it to constrict.
So the consensual light reflex, the other pupil constricting too, happens automatically because of that bilateral wiring at the protectal nuclei. Stimulate one side, both motor pathways get activated.
Precisely. One input triggers two outputs simultaneously. Elegant design. The accommodation reflex, focusing near causes constriction and convergence, uses the same final CN3 parasympathetic pathway for constriction, but the input involves much higher centers, like the visual cortex and frontal eye fields, linking conscious focus to the reflex output.
Okay, we're pulling back from the orbit now, going deeper into the side of the head. These named spaces, the temporal, infratemporal, pterygopalatine fossae, they're not just gaps, are they?
Not at all. They're functionally vital spaces. Think of them as a continuous pathway, getting progressively deeper. They provide attachment points for the big chewing muscles, the muscles of mastication, and they act as major distribution hubs for nerves and vessels supplying the face, jaws, teeth, nasal cavity, really complex intersections.
Let's start with the biggest of the deep ones, the infratemporal fossa. Where is it? What's in it?
It's the space basically below and deep to the zygomatic arch, the cheekbone arch, and it is packed. Key contents include the maxillary artery and its branches, the big pterygoid venous plexus, a network of veins, the entire trunk of the mandibular nerve, V3, as it exits the skull, plus its major branches.
Well,
Also, the chorda tympani nerve carrying taste fibers from CN7 hitchhiking with V3, the otic ganglion, parasympathetic relay for the parotid gland, and the main bulk of two key chewing muscles, the medial and lateral pterygoids. It's incredibly busy anatomical real estate.
okay, contrast that with the pterygopalatine fossa, much smaller.
Tiny, but incredibly important. It's a small pyramidal space tucked deep behind the maxilla below the orbit. It communicates with everything: the orbit, the nasal cavity, the mouth, the infratemporal fossa, the cranial cavity.
And its contents.
It contains the final terminal branches of the maxillary artery, the main trunk of the maxillary nerve, V2, before it branches out, that specialized nerve of the pterygoid canal we discussed earlier, and the crucial parasympathetic relay station, the pterygopalatine ganglion. It's like Grand Central Station for nerves and vessels heading to the midface and nasal region.
Let's link those nerves. Mandibular nerve, V3, enters the infratemporal fossa. How? What does it do there?
V3 pops out of the skull through the foramen oval. It's a mixed nerve. It immediately gives off motor branches to the four main muscles of mastication: master, temporalis, medial, and lateral pterygoids. Chewing power.
And sensory.
Major sensory branches, too. The lingual nerve provides general sensation, touch, pain, temp, to the front two-thirds of the tongue. The inferior alveolar nerve dives down to supply all of the lower teeth and chin. And the auriculotemporal nerve supplies the skin of the temple and, importantly, carries parasympathetic fibers to the parotid gland.
Right, parasympathetics hitchhiking again. Now remind us about the nerve of the pterygoid canal, that composite nerve entering the pterygopalatine fossa.
Yes, a perfect example of nerve bundling. It's formed by two nerves joining together before entering the fossa. You have the greater petrosal nerve, carrying preganglionic parasympathetics from CND7, destined for lacrimal gland, nasal glands, palatal glands. And it's joined by the deep petrosal nerve, carrying postganglionic sympathetics from the network around the internal carotid artery. They merge, travel as one, and hit the pterygopalatine ganglion. Parasympathetic synapse there, sympathetics just pass through.
Okay. And one more parasympathetic player here. CNIX, glossopharyngeal, contributing to salivary function.
Right. This happens via the lesser petrosal nerve. It carries preganglionic parasympathetic fibers from CNIX, specifically targeting the parotid gland for saliva production. This nerve enters the infratemporal fossa and synapses in the tiny otic ganglion, which sits right near V3.
And then how do the signals get to the parotid gland itself?
Postganglionic fibers from the otic ganglion hitchhike. They jump onto the auriculotemporal nerve, remember that's a branch of V3, and travel with it to deliver the secretomotor command to the huge parotid gland located just in front of the ear. Understanding these intricate routes is vital if you're doing surgery or anesthesia in this very deep, complex region.
Okay, shifting down now into the neck. The defining feature here seems to be the connective tissue, the deep cervical fascia. Not just simple wrapping, but complex layers that actually direct how things like infections spread.
Absolutely. The fascia is the key organizing structure. Think of it like architectural layers that compartmentalize everything. And yes, their clinical importance is huge. There are three main layers. The most superficial one is the investing layer. It's like a collar completely encircling the neck, and it splits to enclose the two big superficial muscles, sternocleidomastoid, SCM at the front side, and trapezius at the back.
Okay, investing layer first. What's the next layer deeper, more towards the front?
That's the pretracheal layer. It's mainly in the anterior neck and encloses the strap muscles, infraoids, and the visceral structures like the thyroid and parathyroid glands, the larynx, trachea, esophagus.
Got it. And the deepest layer, behind everything.
That's the prevertebral layer. It lies directly in front of the vertebral column and the deep neck muscles, like the scalens. It forms the floor of the posterior triangle of the neck, and importantly, it extends downwards laterally to form the axillary sheath.
The axillary sheath.
Yeah.
What's that?
It's a sleeve of this prevertebral fascia that extends out into the armpit, surrounding the brachial plexus, the nerves going to the arm, and the subclavian axillary artery and vein. Connects the deep neck right down towards the arm.
And all these layers contribute to wrapping the really big vessels and nerves.
Yes, they form a condensation, a distinct tubular sheath called the carotid sheath. This runs vertically down the neck and contains the absolute lifeline structures: the common and internal carotid arteries, the internal jugular vein, IJV, the vagus nerve, CNX, and associated deep cervical lymph nodes. Protection and compartmentalization.
Okay, now the clinical payoff. The spaces between these fascial layers, they're not empty, right? They're potential pathways.
Exactly. This is where fascial knowledge becomes critical. These potential spaces, filled with loose connective tissue, can unfortunately act as conduits for infection. The classic example is the retropharyngeal space.
Where's that?
It's located between the pharynx esophagus, covered by buccopharyngeal fascia, part of pretracheal, and the deep prevertebral fascia. Infections from, say, the tonsils, pharynx, or even middle ear can easily get into this space.
And the danger.
The danger is that this space runs uninterrupted from the base of the skull all the way down into the chest, into the superior mediastinum. So a retropharyngeal abscess can track downwards rapidly and cause a potentially fatal infection around the heart and great vessels mediastinitis.
Wow, okay. Any other dangerous spaces, like from dental infections?
Yes, Ludwig's angina. This is a severe, rapidly spreading cellulitis, usually starting from an infected lower molar tooth root. The infection spreads into the submandibular and sublingual spaces below the tongue.
And the effect?
Massive, board-like swelling under the chin and in the floor of the mouth. This swelling pushes the tongue upwards and backwards, potentially obstructing the airway very quickly. It's a true airway emergency, all stemming from how infection spreads along these fascial planes.
Understood. Now, landmarks. The big sternocleidomastoid SCM muscle divides the neck visually into triangles, right? Anterior and posterior.
Correct. The SCM is the major landmark. Everything in front of it is the anterior triangle. Everything behind it is the posterior triangle. These are then further subdivided. A key subdivision of the anterior triangle is the carotid triangle.
Why is that one so important?
It's bounded by the SCM, the posterior belly of the digastric muscle, and the superior belly of the omohyoid muscle. Its contents are crucial. It's where the common carotid artery, CCA, typically bifurcates. And right at that bifurcation, you find the carotid sinus, the pressure sensor, and the carotid body, the oxygen CO2 sensor. The body's main regulators for blood pressure and respiration are right there. #XII. Arterial systems of a head and neck. carotid, and subclavian.
Let's zero in on that carotid system. The CCA splits, usually around the top of the thyroid cartilage, into internal and external carotids. Let's talk about the carotid sinus first, that dilation at the split. What's its specific job?
The sinus is all about blood pressure. It's a slight bulge, usually on the internal carotid just past the bifurcation. Its wall contains specialized nerve endings, baroreceptors, that are sensitive to stretch.
So they sense pressure changes.
Exactly. If blood pressure goes up, the wall stretches, the receptors fire more. The key nerve carrying this information away from the sinus, predominantly, is the glossopharyngeal nerve, CNIX.
And what happens when CNIX signals high pressure?
That signal goes to the brainstem, triggers a reflex response. Usually involves slowing the heart rate via the vagus nerve and causing peripheral blood vessels to dilate, both aimed at bringing the pressure back down.
And the system can be overly sensitive in some people.
Yes, carotid sinus hypersensitivity. In susceptible individuals, usually older folks, even mild external pressure on the neck over the sinus, like a tight collar, shaving, turning the head sharply, can trigger an exaggerated reflex.
Leading to?
A dramatic drop in heart rate and blood pressure. This can reduce blood flow to the brain enough to cause dizziness or even fainting syncope.
Okay. Right next to the sinus is the carotid body. Similar name, different job.
Totally different job. The body is a small clump of tissue sitting in the bifurcation itself. It's a chemoreceptor. It monitors the chemical composition of the blood flowing past.
Specifically looking for?
Changes in oxygen levels, low oxygen, carbon dioxide levels, high CO2, and pH acidity. It's also primarily innervated by CNIX. When it detects unfavorable changes like low oxygen, it signals the brainstem to increase heart rate, increase blood pressure, and most noticeably, drive up the rate and depth of breathing to correct the imbalance.
Sinus pressure, body, chemistry. Got it. Now, the two main branches after the split. Let's start with the external carotid artery, ECA. This one branches a lot.
Oh yeah, the ECA is the workhorse for supplying structures outside the skull. Face, scalp, neck muscles, thyroid gland, tongue, even the dura mater lining the skull. It gives off numerous named branches as it ascends.
Can you lift the main ones?
Sure. Typically, superior thyroid, lingual to the tongue, fascial, crosses the jaw to the face, occipital, back of the scalp, posterior auricular, behind the ear, and then it terminates by splitting into the superficial temporal, supplying the temple scalp, and the big maxillary artery.
And the maxillary artery dives deep.
Yes, into the infratemporal fossa, supplying the deep face, jaws, teeth, nasal cavity. And one of its branches is particularly infamous clinically.
Which one is that?
The middle meningeal artery. It arises from the maxillary, heads upwards, and enters the skull through a small hole called the foramen spinosum to supply the dura mater.
Why infamous?
Because its anterior branch runs in a groove on the inside surface of the skull at a point called the pterygium. The pterygium is where 4 skull bones meet: frontal, parietal, temporal, sphenoid, and it's structurally the weakest point of the lateral skull.
So a blow to the temple.
Can easily fracture the thin bone at the pterygium and tear the underlying middle meningeal artery. Because it's an artery, bleeding is rapid, under pressure, stripping the dura away from the bone. This creates an epidural hematoma, a rapidly expanding blood clot that compresses the brain, a neurosurgical emergency.
Okay. Now, the other main branch, the internal carotid artery, ICA, how does it compare to the ECA in the neck?
Completely a different strategy. While the ECA is branching all over the place in the neck, the ICA gives off 0 branches in the neck. None.
Just goes straight up.
Just ascends straight up, protected within the carotid sheath, enters the skull through the carotid canal in the temporal bone, passes through the cavernous sinus, and then starts branching to supply the majority of the brain hemispheres in the eye via that ophthalmic artery we mentioned. It's all about getting blood safely to the brain.
And to provide backup, the brain has that famous circle.
The cerebral arterial circle, or circle of Willis.
Yes.
Yes, it sits at the base of the brain. It's an amazing setup where branches from both internal carotids connect with each other and also connect with branches from the 2 vertebral arteries, which come up from the subclavian arteries.
Forming a complete ring.
Essentially, yes. It creates anastomoses, or connections, between the major arteries supplying the brain. The huge benefit is collateral circulation. If one of the main feeder arteries gets blocked or narrowed significantly, this circle allows blood to be rerouted from the other vessels to potentially compensate and prevent or lessen the severity of a stroke. Doesn't always work perfectly, but it's a critical safety net.
Okay. Quickly on subclavian arterial system, its branches also contribute to the head and neck, divided into 3 parts by a muscle.
Yes, the scalenus anterior muscle crosses over the subclavian artery, dividing it into three parts. The first part is medial to the muscle, the second part is behind it, the third part is lateral to it.
And a key branch comes off that first part, heading up the neck.
The vertebral artery, very important. It arises from the first part of the subclavian that makes a unique journey upwards through the little holes, transverse foramina, in the cervical vertebrae C6 up to C1.
Then into the skull.
Enters the skull through the foramen magnum, and then the two vertebral arteries, left and right, join together on the front of the brainstem to form the single large basilar artery. The basilar artery supplies the brainstem, pons, and cerebellum, and then it splits at the top to form the two posterior cerebral arteries, which also connect into the circle of Willis.
And clinically, that third part of the subclavian, the bit lateral to the scalene muscle, useful for stopping bleeding.
Yes. The third part is relatively superficial as it passes over the first rib to enter the axilla. In cases of severe hemorrhage in the arm or shoulder, you can apply strong downward pressure right behind the clavicle to compress the third part of the subclavian artery against the first rib. It's a key pressure point to control bleeding in the upper limb temporarily. All right, let's talk about the return journey. Veins and lymphatics. With veins draining the head, there's a specific type we need to highlight due to infection risk. The emissary veins.
Emissary veins. What are they? What's the danger?
These are small veins that pass through various foramina holes in the skull bones. Their job is to connect the venous sinuses inside the dura mater, like the superior sagittal sinus, with the veins outside the skull in the scalp and face. Crucially, they are valveless.
No valves. So blood can flow both ways.
Exactly. Flow direction depends purely on the pressure gradient. Normally, blood might flow outwards, helping cool the brain, but the danger is reverse flow. If there's an infection on the scalp or face, bacteria could potentially travel inwards through these emissary veins directly into the dural venous sinuses.
Rating 2.
Potentially catastrophic infections inside the head, like dural sinus thrombosis or even meningitis or brain abscess. It's a direct route for external infections to get inside.
Okay. The main big vein draining the head and neck is the internal jugular vein, IJV, running in the carotid sheath. Lacerating this vein is particularly dangerous because of air embolism risk. Why this specific vein?
Two factors combine. First, the pressure inside the big veins of the neck is often subatmospheric, meaning lower than the air pressure outside, especially during inspiration when your chest expands. Second, the outer layer of the IJV wall, the adventitia, is quite tough and tends to be tethered to the surrounding deep cervical fascia of the carotid sheath.
So if it's cut,
the fascial attachments prevent the vein wall from collapsing fully the way a smaller vein might. So you have an open hole in a large vein with negative pressure inside. During inspiration, air can literally get sucked from the outside into the venous circulation.
and that air bubble travels.
Towards the heart. If it's large enough, it can block blood flow through the right side of the heart and into the lungs, causing sudden cardiovascular collapse. A very serious complication of neck trauma involving the IJV.
Okay. What about the external jugular vein, EJ, the one you can often see crossing the SCM muscle? Is that clinically useful?
Yes, quite useful in a couple of ways. Because it's superficial, you can often see it distend when pressure in the right atrium of the heart rises. So observing the height of the EJ pulse, with the patient partially reclined, gives a rough, non-invasive estimate of central venous pressure, CVP.
And a built-in manometer.
Kinda, yeah. And it's also sometimes used for venous access, like placing a central line catheter. The right EJ is generally preferred for this because it offers a straighter, more direct path down into the superior vena cava and towards the heart compared to the left EJ.
Okay. Finally, lymphatics, the cleanup crew.
Yeah.
Basic rule first, no lymph vessels or nodes inside the scalar orbit, right?
Correct. Lymphatic drainage begins externally. The first line of collection is a ring of nodes around the base of the head and top of the neck called the paracervical collar nodes.
Which nodes are in this ring?
It includes nodes like the occipital nodes, back of the head, mastoid nodes behind the ear, parotid nodes in around the parotid gland, submandibular nodes under the angle of the jaw, and submental nodes right under the chin. Each group drains specific territories.
Like the submental nodes, what do they drain?
They're quite specific. The very tip of the tongue, the floor of the mouth right at the front, the central part of the lower lip, and the skin of the chin, plus the lower incisor teeth. Knowing these drainage patterns is key.
Where does all the lymph collected by this initial ring eventually go?
It all ultimately funnels down into the main deep drainage system, the deep cervical nodes. This is a chain of nodes running vertically along the course of the internal jugular vein, mostly within or alongside the carotid sheath.
Any key nodes in that deep chain?
Two are often mentioned. The jugulo-digastric node, near where the digastric muscle crosses the IJV during console syrinx, and the jugulo-omohyoid node, lower down, near where the omohyoid muscle crosses, drains tongue. But the whole chain is important because it receives lymph from all the superficial head and neck nodes, and directly from many deeper structures too. It's the final common pathway.
So clinically, especially with cancer, finding an enlarged deep cervical node is a big deal.
Huge deal. Cancer cells spreading from a primary tumor somewhere in the head or neck, mouth, throat, larynx, thyroid, etc. Very commonly metastasize to these deep cervical nodes. Sometimes the enlarged node is the first sign of a cancer that's otherwise hidden.
So finding one means you have to search.
Systematically examine all the potential primary sites that drain to that specific node or region of the chain. And in cases where cancer is found in these nodes, the treatment often involves surgery called a block dissection or neck dissection.
What does that involve?
It's a major operation to remove the affected lymph nodes and the surrounding fatty fascial tissue. Depending on the extent, it might involve removing the SCM muscle, the IJV, and sometimes even nerves like the accessory nerve, CNSI supplies trapezius SCM, or the hypoglossal nerve, CNSF, tongue movement, if they are encased by the tumor. Necessary for cure, but can have significant functional consequences. So we've covered a tremendous amount of ground from, tracing those incredibly fine nerve fibers controlling a tiny muscle in the eyelid, all the way through the complex mechanics of sight, the vascular supply, and down into those really critical fascial planes of the neck that dictate health outcomes. This wasn't just a review, it was about integrating it all for that deep professional level understanding.
It really highlights the complexity, but also the sort of resilience, doesn't it?
Yeah.
The backups like the circle of Willis, the intricate pathways.
Yeah.
The body has redundancies built in, but it also means you need really precise knowledge, like with the clinical test for eye muscles, to figure out exactly what's wrong when something fails.
Absolutely. And that brings us to a final thought to leave you with. We spent some time on the deep cervical fascia, seemingly just passive connective tissue. Yet we saw how it dictates the spread of life-threatening infections down into the chest, or how its adherence to the IJV creates the specific risk of air embolism.
Right. It's not passive at all, functional.
Exactly. Its architecture has profound consequences. So the provocation is this. What other structures in the body that we often dismiss as simple support or covering, like, say, the periosteum covering bone or the mesentery holding the intestines, might actually be playing a similar critical architectural role in dictating major physiological processes or the pathways of disease? What other boring tissues are secretly running the show?
Something to definitely think about. A great place to wrap up this incredibly detailed deep dive. Thanks for joining us on this anatomical exploration. We'll see you next time.